Dr. Trish Rawicki is a board-certified family medicine physician specializing in male factor infertility. Dr. Rawicki attended the University of Dallas for an undergraduate degree in biology. She graduated with honors from the University of Texas Southwestern Medical Center and completed her residency in family medicine at JPS Hospital in Fort Worth. Following her residency, Dr. Rawicki continued at JPS as a faculty and attending physician, working with resident physicians to care for both seriously ill patients in the hospital and needy families in an outpatient medical clinic. Dr. Rawicki's primary interest grew to being in restorative health and fertility, so she developed and trained her specialty with the courses in NAPRO technology, fem health, and functional medicine. She has successfully treated numerous women in the Dallas-Fort Worth area. Dr. Rawicki recognizes the deep connection between your lifestyle, hormones, and mental health, and knows we often need to address all of them to reverse disease and improve wellness. She takes a root cause, integrative approach, identifying the underlying issues through testing and using pharmaceuticals when necessary, all with the goal of restoring health. Please join us in welcoming Dr. Trish Rawicki to the NFP Podcast.
Welcome to the NFP Podcast, where we explore the empowering world of natural family planning. I'm Amy Smith. Join me and my co-host Emily Appledorn each week. Together, we're here to dive deep into the science, the stories, and the spirituality behind NFP. Every week, we push back against the free love culture and advocate for a culture of responsible love, where intentionality and respect are at the forefront of family planning. Join us as we discuss everything from the practicalities of charting and fertility awareness to the profound impact NFP can have on relationships and communities. Whether you're new to NFP or a seasoned pro, our podcast is your go-to resource for honest conversations, expert insights, and real-life experiences. So grab a friend, settle in, and get ready to be inspired. This is the NFP Podcast.
All right, guys, welcome back to the podcast.
Hi, everyone.
Tonight, we are very excited to have with us Dr. Trish Rawicki to talk to us about male factor infertility. She is one of the many physicians we've had on, experts we've had on in kind of our doctor expert series here, looking at different reproductive ailments. And oftentimes we focus on females, mainly because there's a lot of infertility issues that come up with females. We've got quite a complex system. But our male partners can also struggle with infertility and reproductive health abnormalities. So Dr. Rawicki is here to speak to those. So welcome to the podcast.
Thank you. Thank you for having me. I'm excited to talk about this because I think it's under-recognized in our field.
Yeah, I would agree. Yeah. And I'm not even like a professional in that aspect of the field, just teaching NFP. It definitely wasn't something that came up very often, even working with clients. It's kind of few and far between. So yeah, we're really glad you're here. Why don't you go ahead and just start, or we can just start our conversation with kind of a general overview of your background, kind of your training and how you got into this kind of a niche field, not only in the realm of restorative reproductive medicine, but just like in reproductive medicine in general, because like we said, male factor infertility is not as common.
Right. Yeah, great. I was originally introduced to theology of the body, I guess. So that would be probably how I was when I became on this pathway. When I was in college, I went to the University of Dallas and I heard a lecture given by a OB, a physician, and then his wife who had a master's in theology. And they synthesized a lot of the physiology of sexuality with the theology of sexuality. And, I was completely overwhelmed with how amazing it was and just hooked right from the get-go, I guess, as a 19-year-old, 20-year-old, maybe college student. And then I went straight to medical school after undergrad. And I didn't really know what I was going to do, but then I did become very interested in women's health in OB towards the end of medical school. And I did a lot of extra rotations in OB. Then kind of in the midst of that, I got married. We wanted to start a family. I didn't really want to do an OB residency because it's just really grueling. I completely see God's grace in that as well, because now that I'm on the other side, I think, gosh, I really don't want to be an OB. Like I like more of what I do from a medical standpoint. Okay. So we all bring really important things to the table. So anyway, so I switched to family medicine and for my residency. And then at the very end of medical school, before I went to residency, I did my first NAPRO training, okay, my like EP, where you learn how to chart Creighton, how to do a medical workup. Um, and that was kind of my first introduction to restorative reproductive medicine. Okay, so this was back in 2013, 2014, I think. So it's been a little while. And completed the Creighton training, went to residency. So I did a residency in family medicine, and I really did not have the opportunity to practice my NAPRO training as a resident. Um, just because it might be interesting. I actually tried in a couple of occasions. Okay, bleeding woman in OB triage. I wanted to put her on some progesterone, was told I couldn't do it. I was managing someone's progesterone in my clinic, just my resident clinic, and I was told I wasn't allowed to do this, and I kind of got in big trouble about it. So it was really fascinating because, of course, we know there's such robust research coming out of Creighton and NAPRO technology, and presented this to my superiors, and it just wasn't really accepted. Okay, so I wasn't really able to practice as a resident, and then but I still was interested. I mean, it was always kind of in me that I really enjoyed this work. Careers take a couple different paths. I think just because I did have a couple little children, I stayed on as academic faculty at my residency, just in a part-time role after residency. So I was working in the hospital as a hospitalist essentially with residents and not doing really any of this. And then COVID happened, and it was just really hard to do that. So I took a full step back from work, and then started teaching theology of the body at to high schoolers, essentially, 8th and 10th grade. And it's called Teen Star. The program's called Teen Star. Through that, just was drawn into a lot of different training, went back to work part-time for my Catholic doctor, and really exclusively doing women's restorative reproductive medicine. And continued to augment my training. I've done FEM training, neo-fertility, and then I recently joined, well, not recently, it's been over a year now, Pearl Health Fertility and Surgery. And that's when our practice really blew up. We started seeing men for fertility. Well, I did personally. And so my practice was started by a minimally invasive gynecologic surgeon. She's an OB. She basically does NAPRO surgery. And then so she's, the surgical and the NAPRO side kind of came to it. And then, I kind of came with this medical side, and was able to see men as well. I mean, OBs can't see men. And then, we've brought, like, amazingly, we're all so thrilled about it. We've brought on Dr. Craig Terzinski. He's opening up a male restorative reproductive lab for us and counseling men. So it's been really exciting, and it's been amazing to have this collaborative effort, all working together. Mhm.
That's amazing. And so you said you can see men just because you're a family medicine
Yes,
physician?
OBs can't. Yeah. And I
Gotcha.
think
Okay.
that's part of why, I mean, I see, many couples that have gone to other clinics, and like the man has never been fully assessed in years of trying, or has had like kind of a rudimentary assessment by a urologist, and we can get into that. Um, but I think that's part of the problem is so much of the original research and like the pioneering of RRM was by OBs who are not trained to see men. So they don't have a license to see men. So I think it's been now that, like, I think more family medicine doctors, internal medicine doctors are getting onto this and working with OBs and surgeons that we've been able to make a lot of progress with the men.
So I guess as you started as a family medicine, like did you start working with men? How did it kind of come up? Like I imagine it was kind of one of those things that you just kind of fell into, like, okay, I just keep seeing couples, I keep addressing this issue, or was it something you set out to be like, I'm particularly interested in male factor infertility. So I'm
Hmm.
gonna, put myself out there as someone who does that and treats that. Or was it more like, I feel like from physicians I often hear like they kind of fall into it. Like I just kept getting presented with this issue and then I just took it up.
I would say I fell into it. Of course, I was trained to see men for just normal things, and as a family medicine resident, we see all comers essentially. And when I started at Pearl, it was just like, gosh, there's a need. These men need help, and I'll be honest, I didn't love it at first, but now I really do because it's so exciting and there's so much we can do for them. And of course, I still see women, so I love working with a couple. Um, and I can get to there's like sometimes some specific some things are a little more difficult with men. And I think that part of that is this idea out there that it's a woman's issue, oh, I thought it was my wife had the problem. Okay, so I mean, part of that is just changing um, this mentality. Like, let's work on optimizing the fertility of the couple, right? As opposed to you're the problem or you're the problem. No, we this is a couple's work and calling. So.
Okay, so what are we talking about? What is male factor infertility? With women we can say they're not ovulating or they have endometriosis or their uterus is having some issues. Like the different parts can have different malfunctioning, things happening. So we say male factor infertility, again, not to belittle the men, it seems like it's an all-encompassing term, whereas in females there's like so many different terms that
Hmm.
are underlying
Mhm.
names for underlying issues that cause infertility. So, male factor infertility, I'm
Mhm.
imagining that's also just an umbrella term,
Yeah.
and there's multiple ways that can manifest. Is that
Yeah.
true? Let's define what we're talking about a little bit.
Yes, 100%. So, okay, so when we're talking about fertility of a couple, because we need two to be fertile, about a third of the time we have a female factor alone. A third of the time we have a male factor alone, and the other third of the time, these are rough estimates, we have both. And in my
Wow, I'm
experience,
sorry. It's really a third, and a third.
yeah, so 50% of the
Wow,
time there's male factor contributing to the subfertility.
that's
No one
shocking.
ever, yeah, no one ever talks about that, I feel like.
Yep. Yeah. So extremely important, right? Half the time we need, and what I would say in my experience, and I'm not sure what your individual experiences have been, but I would say it's the rare couple that I have one issue that is causing the subfertility. That it is much more common, and I use this analogy with my couples a lot, that we have like, let's say, six anchors weighing you down. And if we lift four of them, then we can conceive. Okay, so so yes, I feel like this is a very common recurring theme. The woman has had the last two workup, from head to toe and everything, all the surgeries and and oh, how's the male semen analysis? Okay, so male factor infertility, yes, it's an umbrella term and it's not a great umbrella term. Now, what I'll say is from the world of like the REI physicians, reproductive endocrinologists, in the early 90s, ICSI was developed. It's intracytoplasmic sperm injection. Okay. So they were, and I'll get into this, what that means. But we were already they were already doing IVF for infertile couples. And then when there was male factor involvement, like the sperm was not optimal, they would just take one little sperm, inject it into the egg, okay, and some of the time it would fertilize, and it kind of circumvented all these male issues. Okay, we can find one good sperm, right? A couple good sperm. I would say at that point, any research into male factor stopped. And because, oh, great, we have this way to work around it. We have ICSI. There's a lot of problems with that, with ICSI. But so that's why it's kind of like male factor infertility. Yeah, it's just this umbrella term, and we don't know why, but whatever. We don't even have to deal with that. Well, that we have to deal with that for a lot of reasons. I mean, of course, for couples that want to conceive naturally, even if you're not morally against IVF, I mean, it's many couples don't want to put their bodies through that. And then I'll also say, there's so many downsides, such as increased genetic issues, increased epigenetic changes that can, increase risks of ADD, ADHD, things like that in the children. So there's a lot of downsides to that. And then I would say for the men, and this has become a more, I guess more people are talking about this recently, that semen analysis is a canary in the coal mine, so to speak. It is a very sensitive factor that we can use for men to predict chronic disease way before we have diabetes, hypertension, heart disease. So if we can actually say, wow, we have an issue here, let's treat it early, we can actually lead to improved longevity and improved health span for the men.
So
So,
semen analysis almost sounds like cervical fluid,
mm,
like the power of what cervical
oh,
fluid
yes, yes,
patterns
yes,
in
yes.
female can
Hmm.
show about their underlying health. Semen analysis can do that for men.
Yeah,
Oh, this is
yeah,
so interesting. Okay, keep
yeah.
going.
It's really exciting. So what contributes to male factor infertility? Okay, so it's just, yeah, it means a lot of things. So when we do a semen analysis, we are looking for a couple different things. We're looking for concentration of the sperm. Okay, we want many, many millions, many tens of millions of sperm per milliliter. We're looking for motility. The sperm has to have a nice, moving tail to help it get where it needs to go. We're looking at morphology. Like how is it shaped? Is it able to undergo this really amazing, intense reaction with the egg in order to cause fertilization? Um,
Sorry, I have a question.
yes.
I totally
Yes,
just
go
raised my
ahead.
hand for people that are not able to see me because we're not on video. So morphology, I'm just thinking about, okay, so in the females, right, when we have fertile cervical fluid, our body creates like those channels for sperm to swim through. Does
Mhm.
morphology also mean like the shape of the sperm in order to navigate through the channels?
Yeah, I mean, so any misshapen sperm is not going to navigate as well. Yeah. And yeah, that fully explain that.
Yeah.
And then the other thing that we're looking at, I mean, I'm going to go with the big guys, but something called DNA fragmentation. Okay, so let's say we have a normal looking sperm and we have a really high concentration, but then when we're actually looking at the DNA inside, it's all messed up. Okay, there's a lot of breakages in the DNA, and this has become an extremely important thing that we are looking at, because you will sometimes see men with their semen analysis looks okay, but the DNA is damaged inside. Okay. So that's what we're looking at. And if any of those parameters are not sufficient, so we use the WHO standards. It's looking at fertile couples that have conceived within the last year, and the lowest 5% of those men's sperm. Okay, so we're looking that they fit that criteria. Um, and if they don't fit that criteria, then we in my field, we say why. Okay. And then that can go into a couple different buckets. So we're looking at endocrine issues, which I'm happy to get into any of these, but endocrine issues, infection, um, anatomy issues. Okay, is there an issue with the anatomy? So like a dilated vein or maybe a blockage, so sperm can't get through. And of course, there's a bucket idiopathic, but it's getting smaller and smaller the more we learn. Idiopathic means we don't know. And then, for some of the more severe sperm issues, which I honestly don't see that much, but like something like azoospermia, where there's no sperm, sometimes there's genetic causes of that. Um, yeah, so those are the major buckets.
Okay, so that was a great, I think, kind of overview. Maybe let's take a moment to dive a little bit into each of those if we can.
Mhm.
So, when we say endocrine issues, again, just because a lot of our audience is more familiar with female different
Yeah.
reproductive issues, um, are we talking the same thing like their endocrine system
Yeah.
and the production
Mhm.
of sperm is somehow, their endocrine system impacts that? How does that work? I'm not familiar as much with male anatomy.
Yeah. So it's very similar. It's very similar. We are looking at similar hormones that we look at in women. Okay, so our whole hormone endocrine system all talks to each other. The brain talks to everything else, and the thyroid affects our sex hormones. Okay, so it's all working together. And so for the men, my hormone panel looks very similar to my female hormone panel. Okay. I'm looking at thyroid, prolactin, testosterone. Um, I'm going to forget a bunch, but metabolic health, which is extremely important. Okay, so fasting insulin. Sometimes we're doing a 2-hour glucose tolerance test to really dig in. We're looking at A1C. Metabolic health, mainly meaning insulin and glucose balance, is extremely important for sperm health and for egg health. And estrogen. I mean, men have estrogen as well. I'm trying to think of my panel, but yeah, a lot of different hormones all at play.
Testosterone, I'm assuming, yes.
Yes, testosterone.
Big one.
Yes.
Yeah. Okay. And how about I guess anatomy issues? So
Mm-hmm.
like something with their testicles or with
Yeah,
their
so the
scrotum
main
or
the
penis
main
or
anatomy issue that I see that is actually quite common is a varicocele. And so a varicocele, what it means is a dilated vein in the scrotum. Okay, so the scrotum is outside, the testicles are outside of the body because sperm wants a cooler temperature. Okay, it doesn't like to be, it's not going to work if it's inside the body and hot. Okay, so if we have a varicocele with a dilated vein in the scrotum, the environment becomes too hot for optimal sperm production, and that, yeah, impairs count, motility, morphology, a lot of things, and it can lower testosterone levels as well. um so that's quite common. It increases with age and pressure. Okay, so even if the couple has had children in the past, it might be something to evaluate. um and it's a surgical fix. Um So in that case, I would send them to a urologist, okay, a surgeon who operates on the male reproductive system, and they would repair that varicocele.
is that
Uh,
painful?
a varicocele,
Yeah.
most people don't even know they have it.
Oh,
Mhm.
okay.
Yeah, it's really, really tiny dilatation. So yeah, I mean, if you have a large one, some men can feel it, but I would say most men do not know that they have it. Mhm.
I can speak to the procedure because my husband Josh had one, and it's a very easy procedure. It's outpatient. The recovery time, there's hardly any downtime.
Mhm.
And like you were saying, with it being so common, it's nothing to fear as far as getting it fixed.
Mhm.
So, yeah.
Yeah,
What's
great.
the cause of that?
Well, there are some causes that we know, okay, like pressure, okay? Pressure, just the same way like a hernia would develop, okay? Pressure can cause the varicocele to develop. So I mean, it could be weight, but a lot of times it's not. It's more common on the left side because we have kind of a weaker anatomy keeping everything in place on the left side. And we don't always know what causes that. Mhm.
Okay. How about I guess what would fall under the idiopathic? Like we don't know.
Yeah,
I
I
guess
don't
we
know.
don't know.
I don't
So
know.
I
But I do want to
know.
talk about infection, okay?
Yeah, okay. Oh
Because
yeah, go for it. Okay.
because that is maybe I guess a newer area for our clinic because we didn't have a good way of testing. Okay, so probably somebody in your podcast history or you guys have somebody's discussed chronic endometritis. Is that, yeah, so, kind of a chronic, mild infection in the endometrium. Okay, so it's very hard, difficult to cure. I mean, sometimes we need multiple rounds of antibiotics. Um, we don't always have symptoms of it. Sometimes we have symptoms, but not always. And it causes like an inhospitable environment for implantation, right? It causes just kind of generalized inflammation. And these again, a very common setting. I see these women, they're like on their eighth biopsy for chronic endometritis, and it's like, oh, have we tested husband? And often the husband was being co-treated, antibiotics for both, but so infections these kind of like chronic low grade infections can live in the prostate, in other male accessory glands like the seminal vesicles, even in the bladder. Okay, so we can test the semen and the urine for, a lot of infections. So more than just like STDs. We're not looking for STDs necessarily. Sometimes we are, but we're looking for other things like mycoplasma, blah, blah, blah. And so all of this causes like a chronic low-grade inflammation, which impairs the morphology, motility, and the DNA inside the sperm.
Can you talk about how those can come about if there is known causes, like throughout a marriage? Like how can that happen when it wasn't happening? Do you know what I'm trying to say?
Yeah. Yeah. I mean, I hope I can give a satisfactory answer. I'm not sure it's well known, but of course, our understanding of the microbiome is becoming more robust. Okay. So the microbiome in our gut, and this has been an area of active research over the last 10 years. And, we have a microbiome in our intestines, and we have a microbiome in our vagina, in the bladder, all over our body. And we have billions of bacteria everywhere, and we need a really robust amount of good bacteria to basically keep these bad bacteria away. Okay, so we're constantly coming into contact with bacteria. They come from the intestine, they come from food, they come from the environment, and if we don't have a really robust, healthy microbiome, which happens for so many reasons, inflammation, diet, allergy, blah, 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 then these kind of bad bacteria can just take up residence, and they just kind of hang out and cause problems.
So I guess how I'm trying to think how to word my question here. So for men, how would something, you alluded to it just briefly, but like a sexually transmitted infection, how can that impact male fertility and male sperm health? Because I often hear it again, how it impacts females, but not so much males.
Mm-hmm. Um, yeah, it certainly can impact males. Although Yeah, I would say to the same degree, although probably less well recognized. And a lot of men, when they have an STD, are asymptomatic. I mean, sometimes women are, but men are more likely to be asymptomatic. But yeah, so just chronic inflammation causes problems with the sperm, DNA, motility. It can cause scarring. Okay, so sperm have to come from the testicle. Through the epididymis, up the vas deferens. Like they have to travel a really long way to do what they need to do. Okay. And we can have scarring anywhere along that path that can affect the function and what kind of sperm are in the ejaculate. Okay. So chlamydia in particular is extremely common to cause like scarring of the fallopian tubes, and it can also cause scarring of the male reproductive system.
Okay, so I think kind of having an understanding of all this now, or kind of like a basic understanding,
Mhm.
um, let's move into, how men get diagnosed or how they get, yeah, I guess diagnosed. Let's start there first.
Mhm.
And what is different between, you have restorative reproductive medicine training, and our listeners are very familiar with that term by now because we've had lots of people on that have, and we've used that term quite a bit, versus more mainstream medicine. In the world of female reproductive health, we see stark contrasts. Is
Mhm.
that the same in the world of male reproductive health, or
Mhm.
are they kind of singing out of the same hymnal?
No, I think there's a stark contrast. And I mean, I think in some ways it's wild that I'm doing this in a way because I'm not a urologist. Why isn't a urologist doing this? But they're not. I mean, and I'm sure I know that there are good urologists that are comprehensive but I can tell you some experiences just, sending my male patient to urologists to fix their varicocele. And the urologist says, I don't think it'll make a big difference. You should do IVF. Okay. So and I'll say also some men come to me from a urologist and they've had very little workup, and very little treatment. I would say, the anatomy's been assessed. If their testosterone's low, they're put on medications to increase their testosterone. Okay, which is fine. Sometimes I do that as well. But we're overlooking all these other things that are actually causing the problem. We're treating a lab instead of actually fixing the problem. So I kind of got sidetracked. What was your question?
No, that's good. So there's a difference between restorative reproductive medicine approach, their training versus going to a kind of a regular old urologist or
Yeah, and I think it's a
medicine.
view, it's a philosophy or viewpoint. We see infertility. Infertility is not a disease in itself. It's a symptom of something else. You know, Maybe we don't always find the answer, okay? But a lot of times we do. I would say most of the time we do. We find maybe a couple of things that are contributing. And so we are fixing that. And in the repair of that subfertility or the infertility, we are also improving longevity and health span. Mm-hmm.
Yeah. So maybe,
And
Emily,
how
can
do
we
we
have
do
oh,
it?
go ahead.
You asked me how we do the semen analysis, yes?
Well, I was going to get to that in a minute, but I wanted to ask you too, like for as far as, when we talk about the different female factor infertility issues, like endometriosis and PCOS, there's like a slew of symptoms that women will experience that affect their overall health, their day-to-day
Mm.
function. So when we're talking about male factor infertility and the underlying causes of it, do men also experience these types of, health issues that have just kind of been put off and not necessarily connected to, well, you're having this health issue. And I mean, it sounds crazy for me to say because I've just never heard something like this.
Mm-hmm.
You might be having this health issue because your sperm motility is really low. Like, or that's,
Yeah,
those
and
two
I
things
would
are
say
connected.
it's your sperm motility is low because of something that's causing multiple things. So yeah, I mean, not always, just the same way women can have normal cycles and not get pregnant, that like not always, men are not always symptomatic, but a lot of the time they are. And a couple of things, I think men aren't as used to going to doctors, okay, especially in their 20s, 30s for various, oh, I have anxiety or I have poor sleep or I have sleep apnea. Like they're just not used to presenting to their doctor to discuss that to a certain extent. I mean, low testosterone is also a symptom of a manifestation of an underlying problem, let's say. But just the low testosterone can cause a lot of issues, okay? Like poor energy, poor muscle mass, issues with sleep, sometimes anxiety and depression. And I'll have men, that maybe we discover something on culture and then, oh, I do pee constantly is what they'll say to me. Like, and I really thought it was weird, but I never gave it a second thought. So there's kind of some like chronic prostatitis, like something that was going on that infection was causing. They had some kind of bothersome symptoms, so they weren't ever going to bring it up with a doctor. Hmm.
Emily, do you have any questions? I don't want to keep. Okay. Um, okay. All right. So I guess now we can kind of tackle the, more or less like the Catholic elephant in the room, right? Which is females, we produce cervical fluid that's found on the outside of our body. This creates a pattern with our charting. It just seems a little bit more non-invasive and morally licit to examine and diagnose females.
Hmm.
Now, men, we're talking about semen analysis, and we all know how semen usually presents.
Hmm.
And that's usually done in a very specific context.
Hmm.
However, men also experience other times when they have, semen
Hmm.
fluid
Yeah,
that comes
sure.
out. So, not necessarily only during the point of ejaculation when they're having intercourse. So, anyway, the collection part of it. How
Mhm.
do we get the semen analysis in a way that is respectful to the dignity of men and the
Yes.
marital act?
I love that you phrased it that way because that is exactly how I feel. Yes, men have become so accustomed to having their dignity violated that they don't even think twice about it. And so, yes, we always want to respect the dignity of the individual and the dignity of the marital act. So it's not always easy. Okay, so I'll say that. So we can evaluate in two different ways, which we offer to our patients. We are not necessarily a Catholic practice. We are all Catholic providers, but um, if they choose not to do it this way, it's okay. They can still work with us. But so we offer them, it's essentially a condom, okay? And there's a little hole, a tiny hole with a diabetic needle poked into the condom, okay? And that is worn during intercourse. It collects the ejaculate. They dump it into a little cup and send it off in the mail, okay? And it gets there same day. And that is still not easy for all couples, right? It can feel transactional. It can feel, they've never experienced this before. It can be difficult. So I'm really excited. We've recently introduced, gosh, I hope I can talk to you about the science of it, but it's basically a post-coital test that the couple can do at home. So they have, intercourse just like they normally would. And then, as we know, there's a little bit of like semen and cervical fluid that comes out of the vagina afterwards. And it is collected, and you hook up this little thing, like just collected with like a little pipette on a slide. Okay, a pipette, like you just, I guess, like a little sucker thing that just collects it and puts it on a slide. You hook it up to your phone, okay, and that can analyze the sperm, and it actually makes a video. So this would be a Dr. Trzynski thing he does at the clinic. I don't do it because he's going to run the lab. But he would evaluate what the sperm looks like, the concentration, how it's interacting with the cervical mucus, which is really cool. And assess that way. I'm not sure that there's a way that we can get culture yet using that method. But yeah, it's really exciting for our couples. Mhm.
Gosh, that is so fascinating. Because I
Yeah.
remember we haven't done our topic episode on this, but we have one of our topic episodes that I'm wanting to do is called awkward intercourse because sometimes intercourse can be a little awkward, but especially when you're struggling with infertility and you have to do the perforated condom thing.
Hmm.
I know that was a very awkward
Yeah.
awkward time for us as a couple. It was like, okay, quick, get this. And we had to, luckily we had a hospital that was very cooperative and willing to help, but
Mhm.
our NAPRO physician had ordered it. So we did the perforated condom thing. And then like immediately after, Jody had to like run it to the local hospital to get
Mhm.
tested.
Yeah.
So anyway, yeah, it can be a little bit awkward, but at the same time, it's still within that act. So I think more awkward would have been, have him go into some room and
Absolutely. They
masturbate,
just
which
walk
is just,
out and everyone's
yeah, it
looking at
just feels
them. It's
very,
unbelievable.
I can
Yeah.
see, I've only recently heard, and it was in a secular connotation, but heard men talking about that and how I think in the media, I've often only seen that portrayed as like something that men would enjoy doing. I've
Mm.
never heard a man actually in the real world talk about that it's like an enjoyable experience. They actually describe it, which again is kind of interesting coming from a male perspective, in a way that a female might describe something similar, like a violation. Like there's
Oh,
something wrong here with what I just did. Like I don't feel good about this.
yeah.
But doing it for, medical reasons and health
Right.
reasons, like trying to get that. But the means, I think it just puts even further emphasis on that belief that the means to the end really does matter a lot.
Absolutely.
So, yeah.
And I
You
think I think couples are already struggling a lot. They've been on this infertility journey. There's this pressure. We're in the fertile time, and there's already like a performance anxiety that's building. And then it's like, okay, well, also put on this condom and get ready to rush to, and there's so much. And I really do feel for the couples so much going through this journey. There are so many variables, and so I'm excited that we continue to progress in learning how to help them. Mhm.
So the thing you were referencing with the pipette and the video, is that something that you're able to currently offer, or is that something
Mhm.
coming? That's something
Yeah.
that, okay.
Yep.
So,
Yeah.
um,
It's called
Amy,
home sperm test. Yeah.
what's it called?
YO home sperm test.
And so if someone was interested in doing that, they would contact Dr.
Just our
Craig.
office. Yeah, just our office. And they'd have to make an appointment, I think, to get a chart, and then I'm sure it's not going to be covered by insurance probably, but I think there's some kind of discount code, and then we would ship them, or they could come pick up the kit. Mm-hmm.
Oh, I just lost my train of thought. I was going to ask you about, is this something that they can do telehealth, or is this
Mm-hmm.
an in-person appointment that is needed to initially create contact?
Yeah, no, telehealth is great. Mm-hmm.
I
That's
feel like
amazing.
I feel like so many couples would be interested in this just to
Yeah,
have more information, to be
yeah,
able to see a video. I want that information. I'm
yeah,
just
No,
like,
that's so cool.
that is
yeah,
amazing. That's
yeah.
really amazing. I didn't know. Are you guys the only ones utilizing something like that? Do you
I
know?
don't know that that's the question I'll have to ask Dr. Trzynski. Um, he obviously knows so much, and so he's the one who brought that to our clinic. Um, but yeah, I don't know.
That's great.
Yeah.
Very
That's so
good.
amazing. Yeah. We'll link information to that and to your practice in the show notes for those that are interested. So, okay, so that's how we can get this semen analysis in a way to kind of assess the health of men and get them back into a state of, reproductive health, really, right? Is that what
Yeah.
we would call it?
Yeah, absolutely.
Yeah.
And I feel like I failed to mention really basic things that men can be doing to preserve their fertility. That I
Dr. Rawicki, let me just interrupt you for a second. So, nowadays, right, especially only like well, probably your age too. I think we're all kind of around the same age. Um, it's weird for me to be pregnant, which I still have to remind myself, like, oh yeah, culturally, this is kind of strange at 39 to be pregnant again because I already have 3 kids.
Yeah.
So my husband should already have a vasectomy or be on the way to there.
Yeah.
And so given that kind of that thought of like, okay, well, we know now, which is a great thing, right? Like we're starting a greater appreciation for the fact that women ovulate. We know ovulation is a sign of health. We want to preserve ovulation. So we might be veering away more from, different medications, right? Contraceptive methods, even like tubal ligations, something to interrupt the female reproductive system. Let's keep that intact. But I don't feel like there's quite a knowledge or appreciation for male factor
Mhm.
fertility, just male fertility health.
Mhm.
And it's kind of like, well, men can still have their hormones working and still have their bodies working. And so it's so less invasive to their health if we just do the vasectomy thing. So can we
Mhm.
just take a moment to kind of assess that thought pattern? Like, what's wrong with that thought to say vasectomies are kind of no big deal for
Mhm.
males' health,
Mhm.
overall health?
Mhm. Yeah. Um, well,
I guess, is that true to say? Like, vasectomy is kind of no big deal. Men can be totally healthy with a vasectomy or no vasectomy.
mhm. I mean, I think that they are relatively safe procedures that don't have many complications. Um, a vasectomy, I guess the thing that I would be maybe concerned with is anytime you do some kind of instrumentation of the scrotum, okay, that would happen with a vasectomy, is that you are at risk of affecting testosterone and introducing infection. So, potentially could those be lowered? Um, I don't want to overstate that though. Yeah, especially not somebody who does the procedure.
Right.
Yeah. Mhm.
Okay. So
And
there
sorry,
is,
I would
go ahead.
just say, I mean, I just think like regret and depression can affect more men than we think. Okay,
Mm,
you had your 2 kids and you're 32 and blah, blah, but then, we none of us know the future. We don't know what will happen. And there's quite a lot of um men that do regret it. Same with
oh,
tubal ligation. Mhm.
right. Yeah, that's an interesting point to make. Okay,
Mhm.
but as far as like their overall health is concerned, a vasectomy is definitely, we can't equate it to something like a birth control pill that can totally just wreck a female's system.
No, I don't think
Okay.
so.
Okay. Okay, sorry. I think I kind of veered us off there. Where were we before that? What were you doing, Emily? You had
I
asked a
think you
question.
were I think you were going to refer to just daily habits,
Oh,
perhaps,
right.
Yeah.
that can really
Right.
help.
I just feel like I kind of overlooked when I was talking about different causes of male factor infertility. Just these big buckets. Okay, so the are somewhat surprising to men. I mean, smoking, alcohol, and obesity. I mean, those are huge. Okay. Um, so any kind of nicotine, dipping, even a nicotine patch, sadly, if they're trying to quit, that does affect sperm. Excess alcohol, and I would say, alcohol is probably a toxin no matter in any quantity. But, if we can keep it to less than 4 drinks a week, that is recommended. Um, and obesity, I think people don't, and it's not just the obesity. Okay, yes, obesity, like fat increases your estrogen, it converts testosterone to estrogen. So obesity in itself can lower testosterone. But there's also the insulin and the glucose that go along with that. So insulin and glucose are both very inflammatory and they really damage sperm. So this is like a huge bucket, I think, that is overlooked by a lot of current like even urologists that specialize in infertility. They just don't consider, they'll say like, oh, maybe exercise, eat right, but they're not, treating obesity, they're not treating insulin resistance. And I think that's a really overlooked area that needs to be dealt with.
And so addressing those lifestyle factors,
Mhm.
again, just to make a reference for people who are more familiar with females. So something like PCOS that might have different lifestyle factors that are that underlie kind of the causes or symptoms that we see in that condition with male factor infertility and the underlying causes of that. Life simple, quote unquote, simple lifestyle changes you're saying could have a
Mhm.
profound effect
Yeah.
on their sperm health.
Yeah. And even just thinking about this, I don't know, maybe this is too revolutionary, but even introducing this concept to men in their teens, and boys in their teens. Um, and maybe they don't care about fertility at that age, okay? But even saying it can lower your testosterone, okay? And then you will feel fatigued and you may not, have the libido that you think you're going to have, and you're going to be more at risk of heart disease. So kind of getting a little bit of buy-in, I think, so that it becomes something in their mind as they're growing and considering adopting some of these bad practices.
I'm curious because now I think it's pretty easy, at least I find it somewhat easy to present this information to young girls with the focus on not even using the term fertility. We just use the term ovulation. I just did a presentation last weekend and I didn't use I don't think I used the word fertility once. I just said you have ovulatory cycles, you are entering into puberty when ovulation is starting. Ovulation is the sign of health. Here are all the health
Yep.
benefits of ovulating regularly, et cetera, et cetera, et cetera. So, is there a way you think then that what terminology could we use to present to young boys as they're going through puberty, sperm production is starting?
Mhm.
Because, we did already say, like, for them to get something like a vasectomy is not as overall detrimental to their health as something like females shutting down the reproductive system with a birth control pill. So what I guess case can we make to men to say, "Hey, you want to be producing healthy sperm for the whole of your, reproductive life," which maybe we
Mhm.
should define that too. Like, what is a male's reproductive life? Isn't it just from the start of puberty until they die? They pretty much are always making sperm. And
I
why
mean,
is
it
that
can go
important to
down.
their
Yeah.
overall health?
Mhm.
Go ahead.
Yeah, you're exactly right. They continue making sperm forever. It can go down, especially 70s and up, but really it does start to go down with age. But yeah, I've this is something I've thought about. And I don't know the answer. I don't work with young boys as much, but I do think men want to be masculine. They want to have muscles. I have a teenage boy, and he wants to get abs, and and he wants to have energy, and he wants to be good at sports, and be able to perform on the athletic field, and so yeah, I think linking testosterone to that might be a way to get that buy-in. There's some stuff coming out. I don't know how well accepted this is, but that, if we're sitting around playing video games and not like socializing and engaging in normal social interactions, that our testosterone's lower, right?
Mm.
So so yeah, I think kind of saying like, what kind of man do you want to look like when you're 24? What or
Mhm.
and act like? Do you want to be able to provide for your family? Do you want to have the energy to, do blah blah blah? And yeah, so thinking about preserving that fertility. So, move your body, don't sit around playing video games all day. Eat real food sometimes.
Mhm. Mhm.
Of course, they're teenagers, they're gonna eat, but sometimes, pick up a veggie, some protein. Yeah, so I think that could get buy-in, but I'm not 100%.
So more like framing it as, I think so I just have boys and Emily and I have talked about this before too, but I think, even just in my young dialogue with them, about their body parts, because they're just so
Mhm.
curious about their own body parts and why
Mhm.
is this, mom, why is my penis standing up? And why is this doing
Mhm.
this? And just having very like affirmative conversations with them
Mhm.
about like, because you're a boy and the blood is
Mhm.
rushing to that part of your body. And,
Right.
my twins are 4, like they don't really know what I'm saying, but they're like,
Yeah.
oh, like there is an answer to that. And it doesn't mean there's anything wrong with you.
Right.
And this is a good thing. And I think
Mhm.
sometimes because, I don't know if it's just like a media thing or real lived experiences too, and statistically could be true as well, but like a lot of abuses have come from the male side to the female side. And so we see male virility, right, as like it could be a potential negative or a threat or something bad. And I think somehow changing that conversation. So, you should be proud of your masculinity and the way
Yeah.
God made you and
Yes.
your virility and vitality. And to your point, right? Like you want to be kind of the adventurous, high spirited, feeling great, being strong, defender, protector type of man. That's a great thing to become. And you shouldn't feel shame or bad about that, and having healthy testosterone. Here's how your body works. Your body is good. I think having those same messages for men. I know Bishop Robert Barron, he had a great conversation, I forget a while ago that I listened to. And the question was asked something about, men and women. And he said, well, why can't we raise them both at the same time? Like, why can't both be elevated equally? He's like, because
Mhm.
that's the true Catholic view
Mhm.
of men and women is that they both have roles. They're both good, And um anyway, I
I
think about
love
this a
that.
lot as a mom of just boys.
Yeah, a virtuous masculinity. I think that's actually Dr. Trzynski has talks about that virtuous masculinity that we need to be, yeah, forming our young men that their yeah, their virility, their strength is beautiful. It's great. And we need to channel that to virtue. And yeah, your point, Amy, was so good about there's a purpose. And I would say some of what I tried to do with yeah, my teenager. There's so much about puberty that's really uncomfortable and awkward. I mean, acne or like you'll put on weight before you grow in height or and like yes, that there's some discomfort there and really having that empathy for that, but it's the process to becoming the man God made you to be. And acne, we're getting like surges of testosterone or and that's good. We want a healthy testosterone. Your body will kind of get used to it. And so kind of normalizing, I think, some of that discomfort. And yes, that there is a purpose. We're not just things are not haphazardly happening to you. There is an order. And sometimes can be hard to make sense of, but that if we look deep enough, we can find that order.
So you were talking about different lifestyle things. Can
Mhm.
you also talk about supplements for, I guess this could be a twofold question, like young boys that what they could be taking just to be healthy and have good sperm, but then also for couples that are trying to achieve. Is
Mhm.
there a difference?
Mhm. Yeah, I mean, I guess I can't say the best way to get our nutrients is from our food. So my approach with young men would be eat a wide variety of colorful things and protein. Okay, I mean, I like animal protein. Like clean. It has so many bioavailable nutrients and move your body regularly. Um, So, and then if we have gut issues, address that. Okay. For couples with infertility, yeah, there is data for CoQ10, vitamin C, L-arginine. It's like a good vasodilator. So um, there's other ones, but those are like the ones that I think have the most data behind it. CoQ10, 200 milligrams daily.
Um, I think we're about ready to wrap up here. I guess I'm just curious how many couples do you think are s- or how should I phrase this? I guess I've heard from so many women and couples that, when they go to the IVF clinic, they do like a couple things for the woman and then they just say, okay, well, your best hope is IVF, after like a couple blood draws and maybe some letrozole thrown at it. It's like, okay, well, you haven't gotten pregnant, so let's just do IVF. That's your only hope. I guess, which can be very demeaning for a lot of reasons, but primarily because there's a health issue here, to your point, right? Infertility is not the disease. There's something underlying that's causing it. And so how many of those cases, I guess I'm just curious, do women get all the things done, go through everything, and then they're still not able to get pregnant? You know, I just, as time goes on, it's like how often do men get left behind, and then
Mhm.
someone finally, it's like by the grace of God, they find you, right? And they're like, oh, well,
Mhm.
maybe we should look at him. And it turns out,
Mhm.
oh, wow, it was him the whole
Mhm.
time.
Mhm.
How often is that really the case?
Well, I think most IVF clinics or REI doctors, I do think they do assess male sperm relatively soon, because they're usually doing IUI. Okay, do a couple of things and then go to IUI and you're assessing sperm while that's happening. But are we doing anything about it? No. Like usually it's like if the sperm looks bad, then they're encouraging IVF pretty quickly rather than, and maybe if the couple gives pushback, okay, go to the urologist, see if there's something surgical they can fix, or maybe Clomid will help boost your testosterone. So I think there's a few things that are done. I do think that. Um, but yeah, it's not kind of the whole comprehensive, let's dig till we find it because we want to help you. It's a real I mean, I think it's extremely common, right? I don't think I I think there are so many couples that this applies to, and actually, there we are not we the RM world is doing a study currently to look at the couples that come to us that were evaluated or maybe even went through IVF and asking them what was done just so we can see like what is the difference, okay? And so that will be studied and then we'll have an answer. But I mean I certainly see a big difference, okay? Um and then the other thing that I would note about that is um I just think this mentality in the culture that um maybe it's an instant gratification or maybe it's what's sold to them by the IVF clinic, but healing the body takes time and it can be very frustrating for a couple when they come to me and I tell them things are going to look all the way better in a year. That's very hard for them to kind of grapple with because month by month, they're trying and they're not pregnant. And so that's something I've changed my practice is setting expectations early. Maybe they're not happy that initial visit, but at least they're not upset 4 months in that they're not pregnant yet. And yeah, so I think that's been, really a disservice. Oh, I have abnormal cycles. This pill the pill is prescribed and it fixes it tomorrow. Okay. Or I want to have a baby. They're doing IVF next month. So it's a mentality that we really need to change. Mhm.
When it comes to men, so would you say a year from now, that's both for the man and the woman, or mainly their fertility as a whole? Because I was going to have you or ask you to talk about, after implementing these lifestyle changes and things for the man, do you see a difference like in 90 days? Or is
Mm.
there like that, that time frame where you can say if this is or isn't working?
hmm Well, I'm definitely trying to do things as quickly as possible. That's my goal is to help them conceive as fast as possible. And that coincides with their goal. Um, I would say in my experience, it doesn't always work that way. And I'll give you an example. So let's say we have obesity as a big issue, okay? And we're treating that. We're treating it with lifestyle, but we're also treating it with medication. Okay, if that man, their semen analysis looks terrible, okay? And we identify significant insulin resistance, high estrogen as a problem. So we're treating that obesity. Okay, well, if they lose like 40 pounds in 3 months, then their body's like, oh, I'm starving. It's not a good time to reproduce, and their count can actually go down. Okay, so sometimes we'll do an intervention, and I'll see great positive change in that 70-day sperm life cycle. Okay, that's how long a life cycle is for a sperm. What I would say is that in my experience, it's usually 6 to 9 months. And so, they come to see me, those first 2 to 3 months, we're investigating, we start treatment, and then we're really looking at 6 to 9 months. And um, 6 months out, I'm seeing that their semen analysis now looks perfect. Okay. And now we can be trying to conceive before it looks perfect. That's fine. But it just sometimes I think takes longer than couples care to hear.
I think this is gosh, this is making me feel so I'm not as familiar with a lot of I'm very familiar with a lot of the NFP methods, if you will, but I haven't taught a lot of them. I've just done Creighton.
Mhm.
But even in my Creighton training, and Emily, you can speak to this too if I am wrong here, but yeah, the male part of the introductory session is like one slide and it's very
Mhm.
simple and it presents it as being very simple. And for the most part, it is. They don't have cycles, right?
Mhm.
But yeah, we fail to kind of take that opportunity, which often is presented, when we're working with our Catholic couples during their pre-Cana time, is to at
Mhm.
least plant the seed that,
Mhm.
hey, because I feel like that's what you do in pre-Cana NFP is you're just kind of planting
Mhm.
as many seeds as possible. So that way, when they get to that point, they remember like, oh, that NFP teacher said something about cervical fluid. And in
Mhm.
this case, it would be something about male factor, like, oh,
Mhm.
maybe something with my, the man can be thinking, oh, maybe I'm not ultimately healthy. I think seeing their fertility as also a sign of health, that's
Mhm.
just not, even in this world, and we're all immersed in this world, even you more so than us, right? Dr. Rawicki is like, you work with these men, but to just see this as like, oh, this really is a both of us, like both of us coming together.
Mhm.
Fertility takes two and to see that, yeah, we want you to be healthy as well. And you might not be as healthy, which I think we all just kind of, I say that as an NFP teacher, like in the periphery of my mind, but
Mhm.
not really meaning like, oh, yeah, this actually really could be something that you're struggling with too.
Mhm. Yeah, and I mean that's why I know, it's so difficult for us to find a time and all that, but I'm just like, no, this is important. Like
Yeah,
we need to it's a bit of a crusade of mine, I guess, because I do think, yeah, we need to get that out there that there's no blame, but that the fertility is a couple's journey.
right.
And we need to optimize the couple.
Right. Yeah. I think that could be very empowering
Mhm.
for men too. Yeah. So, I guess as a way to kind of wrap up, we'll link to your practice, so people can see that to my Catholic doctor. But I guess what
Oh,
are the
Pearl Health, yeah.
Pearl Health? Yes,
Yeah.
and I'll also link to my Catholic doctor just because that's also a great
Yes.
resource for people
Great
to
thing.
find
Mhm.
find some help and get moving in this direction if they need it. Um, but what other resources or information, their books or other things that you would recommend people to kind of seek out and learn from?
Hmm. Gosh, I can't think of something for men. I mean, I always recommend it starts with the egg, um, for women, and then real food for fertility. And I will have to see if these authors have something for the men, because I just don't know about that yet. Mhm.
But it sounds like, when we're talking about especially something like a dietary change, real food is going to be kind of real food for men and
Probably for
women.
both.
Like, yeah, I would
Yeah,
think. I could be wrong, but I'm
yeah.
thinking we're talking the same type of thing. Okay, I will link to those as well in the show notes. Thank you so much, Dr. Rawicki, for
Yeah,
this time. We went back and forth quite a lot for the
yeah.
listeners
I'm
to
glad it
make sure that we
happened.
could fit this. And yeah, she's being blessed with another little one. So dealing that first trimester can be quite
Yeah.
rough. So we'll be praying for you and for this
Thank
little
you.
person. Thank you. Thank you. Thank you. I've learned so much. So I'm really very
Oh, thank
grateful. And I feel
you.
like I can be a better advocate.
No,
for
God bless
this.
you both. I mean, just this is
NFP.
important work, right? Just educating the public, and you reach so many more people than I do in my clinic, and so it's great.
Yeah, hopefully we can kind of continue to share this message and a message of hope, that you are working in this field to restore male fertility, or the male aspect of fertility along with, women, that it does take the two of us. And we want our spouses, our male spouses, to be just as healthy in that realm as our females. So, Emily, do you have anything else you want to ask before we wrap up?
No, I just really appreciate you doing this. Thank
Yeah.
you.
Thank you so much for your time. All right, guys. Well, we will see you in the next episode. Check the link in the show notes, or all the links in the show notes, if you want some of those resources. Thank you so much. Have a good night.
You too. Good night.
Bye.
That wraps up another episode of the NFP Podcast. Thank you so much for joining us today. We hope you found our discussion enlightening and empowering. Don't forget to subscribe so you never miss an episode. We'd love to hear from you. Please connect with us by sending us an email with your questions and stories to thenfpshow@gmail.com. We'll be back next week with more insights, tips, and heartfelt conversations about natural family planning. Until then, love responsibly.